I'm Dr. Brooke. I'm a dentist. I exclusively treat adults who have special healthcare needs, and I am in Jerome, Idaho.
And I am Dr. Paulo Kane. I'm the VP of Dental Services for Delta Dental of Idaho. I also do see patients sparingly, but I do see patients still at a FQHC. And yeah, excited to be here. So yeah, I'll go ahead and take it away then, Jocelyn. Is that okay? Yeah, okay, cool. So Dr. Brooks' part's the exciting part and the fun part. I'm like the dry professor, so I'll start us off and she'll close us out. Um, but my main topic is oral health with substance abuse disorders. And you can go to the next slide, Jocelyn. So a lot of this isn't going to be groundbreaking. It's not going to be anything that's going to blow your mind or anything like that. I would appreciate if people want to step in and ask questions, things like that, because I think it could really stimulate some good collaborative discussions across the different professions that we have here, across the different um, work setting types that we have here, because a lot of it comes down to not only identifying, but how do we get people care, right? So that's a big component of this. So, just a couple things to take away from this presentation. I think most people know substance use, especially when it's done in a way that's abusive, is going to significantly increase oral disease burden. It does for medical disease, it does for oral disease. And primary care teams, whether that's dental hygienist teams, whether that's physicians, whether that's medical specialists, dental specialists, play a big role in early detection because we all know that it's much easier to treat disease when it's early on as opposed to when it's significantly progressed. And our periodontists on the call here can really appreciate that. So the focus, once again, I kind of touched on it, but just how do we do practical screening so that it doesn't screw up the workflow of our day-to-day responsibilities? How do we reduce barriers to get care? And then how do we tailor care to really look at a patient holistically? So you can go to the next one, please. So by substance, I just kind of pick some high level, common substance, I guess you could say. In reality, a lot of them do the same thing, right? Cause the same issues. In dental, there's only so many issues that you're going to see in the mouth, right? So tobacco and vaping, primary thing you're going to notice is periodontitis. Periodontitis would be where there's bone loss, and gum disease is what some people say. So the gums around the teeth are very inflamed, red, puffy, etc. That ultimately can lead to tooth loss because a tooth has to have bone to help support it, to help keep it in place. And then there's also the risk of oral cancer because it can change a lot of the functionality of the microbiome and everything that's in the oral cavity to cause problems. So obviously some pretty bad things. Alcohol is associated with oral cancer. I'll give you some relative risks so you can see like how the weighting is for each of these substances in a little bit. Mucosal irritation. So it just in a person who abuses alcohol in practice, I can often tell because first of all, you look at them and they kind of have a look, they kind of have a smell, right? But then their gingiva just looks irritated, it looks dry, it looks not happy. And then it can also cause xerostomia, which is dry mouth. And then illicit and prescription drugs. So that's take your pick, right? Almost all of them are going to cause caries because of what's in it. A lot of acid. Oftentimes there's sugary things inside of it, and it can cause a lot of behavioral health problems that then make them want to crave sugar. Bruxism, which is teeth grinding, and it can be quite severe. And then increased risk for infection because it suppresses the immune system. So if you go to the next slide. So these are the relative risks that I was talking about. So just to give you a little bit of idea of with the substance and with substance abuse, how impactful it is to cause a risk. So with tobacco, periodontitis relative risk up to 3, oral cancer 2.6, alcohol for oral cancer is 5. And a lot of these are synergistic when they work together, they amplify each other. So the risk of consuming heavy alcohol and tobacco, it has kind of that compounding risk and it increases even more. Methamphetamine, rampant caries, excuse me. So what we also often say in the dental world is meth mouth, and it's a thing. Like someone will come in and you'll just see these massive black spots all over their teeth, and you're like, I think I know what's happening here. Cannabis, weed, whatever you want to call it. Xerostomia is the most common thing there. Similar with vaping, vaping can also cause periodontitis, similar to smoking, and high caries risk. So a lot of vapes, I don't even know what they're actually called. Like the flavoring, I guess you could say, is laced with sugar. So obviously, whenever you're uh, inhaling something and then it's coating all your teeth and all your gingiva, etc., and you're doing that over and over and over again, it's just constantly coating your teeth in a bath of sugar. So not good things come from that, and very likely to have high caries risks. And then opioids, whether that's you're taking it as prescribed or if you're taking it, from someone on the street when you shouldn't be, it can definitely increase the likelihood of xerostomia, dental caries it increases, and periodontal and oral infection risk, because once again, it can have immunosuppressive conditions. And for those physicians on the call here, you guys know this probably better than I do, but there's also a lot of mental health changes there. So it changes the psychology of, am I going to brush my teeth today? What am I going to consume in my body? Am I going to drink 3 liters of Mountain Dew today? Obviously, not good side effects. So go ahead and go to the next slide. So what do we do for these folks, right? There's a lot of barriers that we're working against. There's patient level, there's system level, there's provider level. So patients are scared, they're embarrassed, they can't afford it sometimes, they can't get to their appointments. At the system level, where do you get dental access? If there's a place like where Dr. Brooke works and they accept their insurance, it could be, I'm not saying this happens at Dr. Brooke's office, but it could be a long wait, right? Because they're serving a huge wait list of people. They might not have the coverage that they need from insurance or from state programs. And then for providers, especially in the medical world, you guys are so busy. You guys have tons of stuff to do. You're dealing with huge problems that are systemic and extremely complex. Um, the oral health cavity is difficult to apply time to, right? Because you're dealing with some really huge issues in addition to oral problems. So these are the barriers that we're working against. You can go to the next slide, please. So how do we overcome some of these? And, a lot of this sounds good, but in practice, it's extremely difficult. So part of this presentation too is the takeaway is Delta of Idaho is a little plug. We're always looking into how do we overcome these problems? How do we solve for some of these problems? So if you want to collaborate, please reach out to myself or our community outreach team because they're amazing. But if in the medical setting we could normalize oral health screenings, and a lot of medical providers do this, so kudos to y'all. It's amazing. But just to make that normal so that a patient expects that when they go to the physician's office, obviously use non-judgmental language. Think about the history of how they got to this place. So there's no judgment there. You're not shaming them. If I have someone come to my office and they have caries everywhere, I just say, you're here now. Let's get you taken care of, and then we'll trudge a path forward. So let's circle back to the past when we need to solve for those issues. A lot of places also have care coordinators. So I know the community health centers, the FQHCs, the family health services, Terry Riley. We did a grant with Terry Riley for care coordinators. That can be a really nice way to kind of bridge that gap from getting someone from their medical setting to a dental place of care so they can get treatment done. And then bring oral health into the entire holistic health discussion. So let's say, someone's suffering from drug addiction. Okay, yeah, there's the mental, the behavioral health piece of it. There's the systemic piece of it, but we also got to address this, elephant in the room as well, because that's really closely tied in. You can go to the next slide. Are there any questions so far? I haven't been paying attention. No? Okay, cool. So this is Dr. Brooke's going to get into this stuff a lot more and give a lot more detail, and it's going to be really good content for you. So I'm just going to kind of provide some high level, because in dental we're kind of limited in our prevention strategies. We don't have a lot. The teeth, believe it or not, and the gums and the bone are extremely complex, and there's only so many things that we can do to prevent problems and to also treat problems. So as Dr. Esplin knows, especially with periodontal disease, you heard me mention that multiple times, you can't grow bone back. You just can't grow bone back from nothing. So once that happens, it's very difficult to treat. It's also very difficult to prevent that if people are engaged in these substance abuse behaviors. So A lot of these are more focused on caries prevention and then the psychological component of it. So that how do we not get to this place? So high fluoride toothpaste or varnish. So it's high fluoride toothpaste. You can do like a 5,000 part per million of fluoride. So it's 5x of what you get at the grocery store. And that's a prescription typically. Dr. Brooke will talk about that more. There's also varnish. Varnish is, I think it's 13,000 parts per million. Brooke can correct me on that later, but it's a very high strength fluoride. But you literally just paint it on. Like my 5-year old could do it very easily. It's not rocket science. It's not difficult, but it can be very highly effective for a lot of the people in these populations. It can be done in a medical office very easily. There's nothing that would really be a barrier to applying that sort of thing. Saliva preserving strategies. I'm sure Dr. Brooks is going to talk more about this. These, what I found in practice, like it's so whether they work or not. Dealing with saliva flow is it's a very finicky thing. It's very touch and go. And so you kind of find what works for someone and stick to it, but it is difficult. So if we can avoid having a patient have xerostomia, whether that's obviously getting them to not engage in a lot of these behaviors, but then also if we look at prescription lists and how are the interactions happening there to cause xerostomia, that could certainly help. Diet counseling, I jokingly mentioned the 2 liters of Mountain Dew a day. You'd be surprised. And with all the new beverages that are out there, they're just laced with sugar. And a lot of these substances create cravings for sugar, like significant cravings for sugar. Or like I said, with vaping, they contain sugar. Once the body gets used to sugar, sugar kind of tastes good. I like cookie dough, but I'm not going to eat a whole tub of cookie dough, right? So diet counseling is really important. Then obviously, in my opinion, behavioral health counseling is one of the most impactful things, right? If you can't change the psychology of a person from how they got to this point, how do we expect them to then improve from this point, right? So we can do all the dental care we want, we can do all the medical care we want, but if we can't get the mind right, it's going to be very difficult to create a good path for our patients going forward. And then just, in general with medical literature, messaging, education, just if we can incorporate some oral health components into that, I think we're doing a lot better job of that as a profession, as dentists, as medical professionals as well. I think we're really trending in the right direction that way. But just to keep in mind that it really is all tied together, believe it or not. The mouth, like you can look in the mouth and be like, yeah, this person's not very healthy in general. You might look at someone and think, oh, they look like they're healthy, but then you look in their mouth and you're like, oh no, it's a train wreck, and the rest of the body tends to follow. So that's really important. You can go to the next slide. So some tailored treatment. Obviously, we want to keep people out of the ED for dental problems, right? Most dental problems aren't really emergencies, and it's a big burden for the system. And a lot of these patients, what I've seen anyways, I hate to generalize. I'm not trying to generalize here, right? But a lot of them will go to the emergency department for dental care. Like, oh, I have a tooth that's swollen. I'm going to go to the ER because this dentist doesn't take my insurance. I can't get in forever. But if we see that, whether it's typically in primary care, if you guys see something or notice something, even if it's small, if we can get them referred on a pathway to dental treatment, then that will hopefully help keep them out of the ED. I kind of mentioned the medication choices to reduce xerostomia. I mentioned the referring early for suspicious lesions. I think everybody knows that. I think everybody in the system does a really nice job for that. And then from the medical side, if you do note any just small things, even if it's slightly unusual, you don't think it's worthy of a referral to a dentist or what have you, just to document it, because there might be some time down the road where you haven't seen them for a year, we haven't seen them for a year, they come into our office and we note something, and they might say, yeah, my medical provider said something about that. It'd be nice for us to be able to reach out and say, hey, what did your note say about this lesion, et cetera, just so we know kind of some trackability there, some historical perspective. You can go to the next one. Yeah, so in your day-to-day practice, and once again, I have physicians in my family. I have mid-level providers in my family. I know everybody is way more busy than they should be, right? But if you can, even if you're out, even if you're a hygienist and you're just out of the community health setting, like Delta Dental, we do with Grins on the Go, just incorporate a brief oral exam into your regular routine. It really is impactful. It's pretty easy. Ask people about their substance use. What are you doing with your oral health, oral hygiene? Quick look in the mouth, lips, tongue, floor of the mouth. Look at their teeth. Do they have big brown spots? Just real quick, just so you know, and then you can talk to them a little bit about that. And then it just normalizes that oral health component in a medical setting. And then the education, so clear. A lot of people, even people on this call, I don't know, I didn't see who all's on the call, but a lot of people don't understand teeth. They don't understand the why. They don't understand why it's important to, take care of them, and to have things that are clear, that are at a level that people can understand, I think is really important for oral health recommendations. Like, you need to go to your dentist because you have these black spots all over your mouth. Well, they don't hurt. Okay, I understand they don't hurt. But next is what's going to happen is you're going to end up in our emergency department because you're going to have massive swelling all over. Oh, okay, that makes sense. I don't want that. So just very clear, very simple, right? We don't have to get down in the weeds, but at a high level, kind of educate the why, right? And then the best thing possible, and I know it's not always possible, and I totally empathize with this, is if we can do warm handoffs to dental offices, dental providers, as opposed to just say, hey, you need to go see your dentist. The conversion rate of people who are going to actually follow through and get care, especially in this population, the substance abuse population, it really is crucial, because if we don't have that warm handoff, it's probably not going to happen. And I think as dental providers, we can do the same thing, right? We need to do a warm handoff to the medical care to make sure that, okay, we're seeing this, we're seeing it's a problem with substance use. We're going to take care of your mouth, but we're also going to follow through and do a warm handoff to our medical collaborators as well. So that really goes both ways. And you can go next. So yeah, just to sum it all up, substance use, it's a problem, right? It's a dental problem, it's a medical problem. We got to keep working to reduce barriers. That's the only way that we're really going to help to try to solve the problem, and then to work as a team, right? And I don't have all the answers. A lot of what I said sounds great, but it's really hard to do it in practice. And once again, I think if we don't collaborate and really bring the conversation to the forefront as providers on this call, obviously everybody cares, right? So I think if we can continue to collaborate across the professions, across the medical scope, the oral health scope, that we probably can make a difference. It won't happen immediately, and once again, reach out to us at Delta Dental because we want to collaborate. We want to solve these problems. So yeah, I think that's it, isn't it? Yeah, perfect.
Thank you. If there are any questions, please put those in the chat and we'll continue the conversation there. Okay, go ahead, Brooke.
So y'all see my screen, is that right? All right, success number 1 accomplished. Screen share done. Right after I said that, it said your internet connection is unstable. So let me know if anything does not go well with that. These are financial disclosures. I do speak professionally on different things. I do recommend different products, and sometimes people who make those products like to sponsor me to give talks. This talk is not a sponsored talk, but I think in all fairness, you can see some of those sponsors up there. Like you were discussing with the insurance coverage, our insurance coverage currently in places like long-term care facilities is very difficult. And I run a private practice outside of family health services. And I use all of the sponsor money that I get for giving talks. I actually use that money to run our nursing home program. I don't pay myself at all, but our Medicaid pays so little that I'm not able to pay my staff to go out to the nursing home and provide care. So in order to be able to pay my staff, I take all my speaker honorariums from my sponsors and I fund that program on the side. And so I don't know if that goes in with what you were talking about, but these are some of the folks that help out with that. You can see Delta is one of my sponsors, so we are friends. Paul and I are friends. Legal disclosures. I am not familiar with all of the Idaho Practice Acts for all the different categories of medicine. So we're going to go through, we're going to talk about different things that I'll recommend happen. You probably want to check with your Practice Act for your individual specialty and make sure that you can do that in the state of Idaho before doing it. I'll be like, just put this on the teeth or just do that. But like, make sure you can do that legally because I don't actually know. So Paul did an awesome job, I think, dividing things out with like a system level, a patient level, a provider level. I did a less awesome job with that. But those same things that he was talking about with different barriers, a lot of times when you're looking at adults that have special healthcare needs. So he was focused on substance abuse. I'm focused on patients that have special healthcare needs. And those needs may be the special needs that you think of when you think of special needs, but also geriatric patients have special healthcare needs and cancer patients have special healthcare needs. So really it's the whole gamut of patients we're looking at. And when they're looking at behavioral issues, sometimes they're looking at why don't the pediatric dentists just keep all of these patients in their practice forever? And the reason for that, that a lot of pediatric dentists don't do that, is because adult dentistry and pediatric dentistry are not the same thing. And so you don't see a lot of pediatric dentists that are treating periodontal disease, that are doing root canals, that are doing regular crowns, just like you don't see a lot of dentists that treat only adults doing some of the pediatric procedures. And so just procedurally, sometimes these patients will age out of the pediatric office. And then as a primary medical provider for some of these adults, you're going to be with them in that part of their transition. So they're not only transitioning in medicine from a pediatrician to a primary care doctor for adults, they're also trying to find a dentist, and you're going to see them struggle in finding a dentist as an adult. And so hopefully part of what I go through will help you as the person that's treating them as a child, or you as the person who is, they're a new patient, they're an adult, they've now found you and they want to find a dentist. This can help you help them slow their disease while they're looking for a dentist, because it is pretty hard to find us. Uh, Special care dentistry is not an actual specialty in dentistry. And so, like, you can, if you need a root canal, you can Google search endodontists, you can Google search oral surgeons if you need your wisdom teeth out. It's harder to search for people who practice special care dentistry because we don't have an official title, because we're not a recognized specialty. So there's a lot of general dentists out there. We have an organization called the Special Care Dentists of Idaho. Casey's in there. Hello, Casey. She's actually the president of Special Care Dentists of Idaho. And so that's a good starting place to look for dentists who are comfortable seeing these patients based on what their individual needs are. Paul touched on Medicaid issues, and the reimbursement rates are just so low. They say it's an educational issue, and the dentists don't learn how to treat some of these patients when they're in school, but we also didn't learn how to do implants when I was in school, and I can tell you all my colleagues know how to do that. And it's just because you don't get paid to see these patients. Like, seeing these patients oftentimes costs the practice money. And so it's difficult for people to take Medicaid and to see patients that take a longer amount of time and also get reimbursed. My percentage of regular reimbursement is 27%. So Medicaid pays 27 cents on the dollar on average, and a lot of services that they need are denied. So a lot of access to care barriers that you'll see is because you need to do a procedure and it's not covered. So then you just like do it for free and you go broke. Patients may fear coming to the dentist, and that's just true. Sometimes, like Paul had said, some patients aren't going to show up. They're not going to come. They're going to be like, oh, that sounds like a good idea in theory. Then when it comes time to go, maybe not show up. And some of the dentists have a fear of the patients moving. Dentistry is a precise science. It's like an art and science, and every little bit counts. And then if a patient does like this while you're trying to work, it makes it a little harder. Like, I like that because I like excitement, but not everybody likes excitement when they're trying to do precise work. So that just affects the predictability. And those are some of the major barriers I've seen for some of my patients being able to receive care. So you can help. And the way that you can help is we're going to talk about what dental caries are, so that as a medical provider, you can have a better fundamental understanding of what's going on. You also will have a better understanding of caries risk. So what are things that you can do for your patients to help your patients mitigate their own risk while they're not able to find a provider? And then, as Paul had mentioned, a lot of meds, whether they're illegal medications that they're taking because they want to, or if they're prescription medications that they're taking because they need to, there is a lot of risk factors involved with medications, and then things that you can do with your patients to slow their disease. I also did a course for the Ohio Medical Association. There's a YouTube link on the bottom of the handout there. If you want to listen to us talk about this for like an hour, you can click on that link and we talk about minimally invasive dentistry and techniques and a lot of stuff in that course if this is something that's particularly interesting to you. So what are dental caries? The ADA, we have our definition of dental caries with the ADA, that it is a disease process that is biofilm mediated, meaning that there's this biofilm on your teeth. It's got fungus, it's got bacteria, it's got virus, it's got all sorts of diverse things in there. And that is all going to affect how this disease progresses. It is sugar driven, meaning that a lot of the bad bacteria and the bad things in there, they're going to eat the sugar and secrete acid, making a more acidic environment. The bad guys live better in acidic environments. It is dynamic and phasic demineralization and remineralization of hard tissues. People think of teeth as just this static structure, right? That this is your tooth and you get a hole in your tooth. But really, before an actual hole forms, there's this whole process of it's dissolving a little, it's building back up a little, it's dissolving a little, it's building back up a little. It's not like on Facebook that you can stick a sticker on your tooth and all of a sudden there's not a hole anymore. But there is on a microscopic level demineralization and remineralization before that actual cavitation happens. And it's when that demineralization outweighs the remineralization, that's when you start getting holes like you can see. I don't know, can y'all see my pointer? Where you can see all the little holes over there. Two important distinctions too is that caries is not always an active disease process. You can have somebody, I mean, this guy has active caries, but you can have somebody that looks like this. You can place some topical medicaments over there. You can actually stop that caries disease process from continuing. They will still look like this, probably a little bit darker on their teeth, but you can make that disease process stop. You can stop it from getting worse. It's not going to make their teeth look better, but it's going to make it so they don't get infection quite as quickly. And that's where we're looking at arrested caries. So active caries disease is progressing. Arrested caries, you have definite evidence of this disease, but it is no longer progressing. And I cannot see the chat, so feel free to interrupt me if there's a question in the chat. If I talk too fast and you need me to slow down, you can just interrupt me and tell me to slow down too, because I am an auctioneer by trade. No, just kidding.
No questions at this point.
Okay, perfect. I'm not an auctioneer, by the way, but I probably could be. When we're looking at diagnoses, we went through with how the ADA defined caries, but then in medicine, you guys have your ICD-10 codes, and you have so many different diagnoses for caries. Like I was actually impressed when I started doing hospital dentistry, and I was like, oh my gosh, you guys have a lot of diagnoses. We don't use a lot of diagnostic codes in dentistry, and that's a little bit controversial in dentistry, whether it would be a good thing or not a good thing for us to use diagnostic codes, but it's just not something you'll frequently see in charting. Sometimes you'll see that in a health center. Sometimes you'll see that in like residencies that are hospital based, but in a general private practice, it's really, really rare to see these diagnostic codes used. So yes, you guys in medicine know that they exist, but if you're going to try to collaborate with one of us dentists, we may or may not even know what a K02.9 is. If you tell us like your front office calls and it's like, oh, their diagnosis is K02.9, I'd be like, what is that? Like canine? They have a service dog. And so you do want to make sure that as you're communicating with us that this is not something that's commonplace. The ADA did come up with a few different things with the diagnosis and classification of caries as we're looking at cavities and like classifying them based on how deep and how large they are. And so there's tons of classification systems, by the way. When I was in school, we learned these ones down here where you're looking at E0 and E1 and E2, meaning like how deep into the enamel it is. And then they talk about the IC-DOS, which is another classification where you're looking at it's all based on depth. All of these are based on depth. Then the ADA came up with a more simple diagnostic criterion where it's like sound, initial, moderate, and advanced. And the point of showing you all of this is that our diagnosis is all over the place and it is not standardized as to what that is. Some people would say, oh, well, that's awful because then how do you know that the procedure is appropriate? And some people would say, oh, it's great because we don't get caught up in, does this diagnosis match this procedure in like having billing issues? And it just makes our life a little bit less complicated to not focus on that. So big difference between medicine and dentistry when we are communicating. Diagnostic codes kind of are a thing, but not really. So here's the oversimplification of the caries process. These are my cute little bacteria. I learned how to draw in Microsoft PowerPoint, so hopefully you enjoy my cute little blue BAM bacteria. These bacteria consume sugar through the metabolic processes. They are going to then secrete acid, and that acid makes your mouth acidic. It's not going to automatically make holes in your teeth, but the longer of a time that you spend with your mouth being acidic without balancing that out and having that process be dynamic where it's acidic, neutral, maybe even a little bit higher pH, right? And having that dynamic demineralization and remineralization, if it's mostly demineralization, you start seeing these little white spots. And then after you start seeing these little white spots, then those white spots start cracking off a little bit. You start seeing these little holes. And then those holes get bigger and bigger and bigger. And then as those holes get bigger and bigger, it can get all the way into the nerve. And that's when you're worried about having those big swellings, when you're looking at this going systemic. And so it is a process that can take any amount of time. I've seen people that have teeth that look like this, and I'm like, you are going to have a huge infection soon, and they look fine 2 years later. And I've seen people who look like this, and they're gorgeous, and a month later they have an abscess because they had chronic bronchitis. And so, just depending on their risk factors, it can progress very quickly or very slowly. I really like to look at dental caries as a scale. And so, whatever you have on this side over here, your risk factors, some of those are very controllable, but some of those are not controllable at all. You have your preventative factors over here also. Some of them are controllable, some of them are not controllable at all. And so when you look at every patient as a unique individual, and we look and see like what risk factors do you have, and is this something that I can help with? When putting this presentation together and thinking that I'm going to be talking with medical providers, I isolated out a few risk factors that we can really work together with our patients to help them with. And dry mouth is one of them to talk about. Dry mouth inducing medications and sugary medications are some of the things that we can focus on with these risk factors. They're not bold because they're more important than the others. They were just bold because they're more germane to like this conversation. But when you're looking with these scales, and we have this scale, like it's available in your handout. If you want this scale for your office, I could send you a Microsoft Word or a little PowerPoint where the patients can go and they can circle like, oh, I have this. Oh, since I have this, I should probably go do something good over here. And that can be helpful for them as well. So this is a slide of a whole bunch of resources. So for medical providers, looking at dentistry can take up a lot of time. And having this conversation, it may not be a conversation that you're comfortable having with your patients. It may be a conversation you're totally comfortable having, but you just don't have time to have. And so I just put all these links in here with the different topics. These are videos that the American Dental Association put out. They're 1 to 2 minute videos that patients can watch, and you can just give them this on whatever iPad that you give them to play with when you leave the room to go do something else. Or if your medical assistant or someone can go in and they can watch that. You can play some of those things in the waiting room if you know that somebody is coming in that needs to hear some of this stuff. So you can check out those videos. These up here are patient-facing videos. So anything that might be able to help you better communicate with your patients and without having to actually be there and communicate. That's what those are. Down here are free continuing education courses for catered more toward medical providers. And so just if you wanted to if yourself have a better understanding of oral conditions, here are some links that you could take a look at and resources for you. So this slide is a very boring, very text-filled slide of toys that you can take home and play with. But this is like real life medication here. We do nystatin all the time in dentistry because when people have oral candidiasis, it works great. However, when you look at nystatin and you actually break it down to how much sugar is in nystatin, if this medicine cup was filled to the 30 milliliters with nystatin, this is how much sugar we're telling these patients to swish. And so, you got esophageal candidiasis and you're like, swish and swallow nystatin. Well, what if they have diabetes? You're like, take a shot, right? And so this is a shot of sugar-laced medication. I've not found much that's better than that. Some alternatives I found that work almost as good are the clotrimazole troches because those can be compounded sugar-free. They have sugar-free and sugary of the clotrimazole troches, and if you don't specify sugar-free, you're probably going to get the sugary ones. But that's helpful. I don't really like to turn to systemic medications when I could use a topical. So the fluconazole down there, I don't frequently go to that, but it is another alternative depending on the patients and their diabetes and just like what's going on with them, especially if they're like doing the swish and swallow or they're supposed to do a swish and spit, but we're treating special care patients and you give them a shot of liquid and they're going to take it like they're in Vegas, right? And so it's just one of the considerations that we have with our medications here. And ChatGPT drew me this lovely monster to show that a lot of medications are just chock full of sugar. I didn't even realize how much sugar was in nystatin. I knew there was sugar in nystatin. I knew we wanted to try to compound. We had a pharmacist that liked to compound, and so I went to go with them to try to compound some nystatin that wouldn't be so darn sugary. Oh my gosh, nystatin is so gross. And so that is why there's so much sugar in there. We compounded it with a sugar-free mixture, and I couldn't even put it in my mouth for a minute. It was so bad. If anyone has any alternatives, please email me because I'm still looking for them. But the alternative we found, super gross, didn't work. But the point is, when we do use nystatin, recognize how much sugar is in there and say, hey, this is not a long-term solution for you. We're going to use this for a couple of weeks. If this doesn't resolve, we're going a different direction. You're not going to use nystatin every day for a long time. This is like when you guys get patients that have chronic bronchitis, or if they start taking a medication like maybe lisinopril, or they have that dry productive cough and they don't like that cough, so they pop some cough drops or they pop some candies in there. When they're using cough drops, I like to say that cough drops are just candy with a publicist, because when you look, this is a popular hard candy. Looking at the nutrition facts, and the sugars are 9 grams of sugar for 3 pieces, so 3 grams per piece. This is a popular cough drop. It is 2.6 grams of sugar for one cough drop. So, like, you might as well be sucking a Jolly Rancher every time that you're popping a cough drop there. There are a lot of cough drops out there that are sugar-free. The only downside with sugar-free cough drops is a lot of them use xylitol, which we love in dentistry. Like, it's great for your teeth. We love xylitol. But if you have a cough and you eat a bunch of xylitol, side effect of xylitol can be GI upset, right? And diarrhea. So cough plus diarrhea also equals a bad day. So you just got to balance those things. So here is a little section just on what can you do to help your patients if you are prescribing medications that cause dry mouth. A lot of medications that are prescribed in my patient populations cause dry mouth. A lot of antipsychotic medications in our population, a lot of medications where they go from having healthy teeth and great teeth, and now they're taking these medications and their life is so much better. They're not hitting their mom anymore. They're not punching holes in the wall. Like, they've actually found this medical balance that's making their life better, but it is like a reign of terror on their teeth. And so we want them to take those medications. We want them to take those medications, even though they're causing xerostomia, because it's drastically improving their life. However, we don't want them to be popping peppermints every few minutes because their mouth feels dry. We don't want them to be sipping, like you were saying, Mountain Dew. Mountain Dew is so popular and it's so gross. It looks like urine, but we want to give them alternatives and say, like, hey, I'm prescribing you this medication. One of the side effects of this medication is it's going to cause dry mouth. When you get dry mouth, there's a ton of options that you can do that are good for your teeth. These are available over the counter. All of these, they're like dry mouth. It's like a lubricant, like a lotion lubricant for your mouth. And most of them taste like Junior Mints. Any of the mouthwashes that have oil on it, oil pulling, in my opinion, doesn't do anything, except for when you have a dry mouth patient and they use a mouthwash that is oil, like an oil pulling mouthwash. The oil is lipid base. Lipid base is a lubricant. So now they're feeling like their mouth is lubricated for a little bit longer because it takes a little longer for your saliva to dissolve that oil. So we actually do recommend some of those alcohol-free oil-based mouthwashes. Aqua Oral is a prescription. I don't have a lot of experience with that one because it's a prescription. It is not covered by Medicaid. And when it is a prescription and it is not covered by a Medicaid, the answer my patients give me almost all the time is I cannot do that. But that is also a lipid-based oral spray. And the people who have had success with being able to get it and afford it have given it good reviews. I just don't have a lot of those patients in my practice. But they can put these in their purse and just kind of put that in as if they were putting in a little time release sugar capsule or a candy bar. So here again, just talking about medications. I think we talked about medications quite a bit with the sugar-free cough drops are a lot better. One of the ones that I like a lot are the menthol eucalyptus ice chips, because you can take the tiniest little piece. Like, these are like you took a big piece of ice and you took a hammer and just knock that up into a whole bunch of pieces. So you can take a tiny piece, so you're not getting as much xylitol every time you take it, so you don't get gas quite as much. And that's why I like those, because the chips are a little bit smaller. But menthol eucalyptus ice chips are a nice cough drop that's a sugar-free alternative. There's a lot of different programs where people are rewarded for good behaviors with a sweet treat. It's so easy to have a bag of M&Ms in your pocket, and those should never be resealable. Like, talk to M&Ms and say, do not make a resealable bag of M&Ms. You should eat them in one setting and be done with it. But it'll be like, oh, and you even see it in our office. Like, we've seen people, oh, sit in the dental chair. Oh, here's an M&M. I'm like, really? Like, right in front of me? But they do. And so we want to make sure that, especially those of you that work with children, that as we're forming reward systems, whether it's reward systems for having good medical behaviors, or if you just see a parent being like, okay, be good at the doctor's office. And if you're good at the doctor's office, then I'm going to give you, you can go get a soda, or you can go get a milkshake, or you can go get a like insert something that's terrible for your teeth here. Maybe talk to them about as a child forming a reward system like you like to ride your bike at the park. If you go to the doctor's office, we can go to the park for 30 minutes afterwards. We're going to go bowling. We're going to go to the car wash. Like supplementing a healthy behavior for a sugar sweet is something that can really, really turn these people's lives around, especially for children. When those systems are already in place, we recommend cereal dilutions. And so if they are using like Coca-Cola as a reward, okay, next time have it be like 80% Coca-Cola and 20% water. And then next time like 70% Coke and 30% water. And so if you can get them down with cereal dilutions to where it gets less and less and less, they don't notice the abrupt change in reward system. And then maybe they'll start liking it less because now it's like, I mean, that's kind of gross. Like half soda, half water is probably not that good. And so now, oh, would you rather have this or go to the park? And then try to change that system. And here are some alternatives. So if they only are motivated by food, like I'm super motivated by food. I definitely doing this course today, came home and ate a quesadilla. But Dr. John's healthy sweets, a little bit pricey, but they're really good. The downside is if you store these in a warm place, like if they're in your office and they're by the heater, you're going to end up with like this conglomerate Jolly Rancher like Christmas ornament. So make sure that you store them in a cool place, but they're really good. These are called Basic Bites. They're like a Tootsie Roll or a caramel. Those are so good. And they have arginine bicarbonate in them. Arginine bicarbonate actually raises the pH of the mouth. And so those are fantastic. The downside is a bag of those puppies is $40. There's a bunch of them in there, but it's still, they don't sell smaller bags. I wish they would because no one's going to buy a $40 bag of candy, especially if they're on Medicaid. But they are very, very helpful. And then ice chips don't just make the alternative cough drops. They have so many different flavors. They even have margaritas. So you can have a margarita party that is totally sugar-free and xylitol with these little ice chips. Paula talked a little bit about fluoride and prescribing fluoride. Here's just some of the 5,000 parts per million fluoride that we have in there. If we are prescribing medications that are going to cause dry mouth, or we do see that there's a lot of sugar sweetened rewards or a lot of sugary medications, prescribing the 5,000 parts per million fluoride toothpaste along with that is going to put something on that good side of the scale. So now you're weighing in favor of not having cavities. And then I've got a couple of my favorite prescriptions for that right here. The personal favorite is the gel, especially working with patients who have autism, because with autism, textures matter so much. And if they're on Medicaid and they are using the paste, it is like you dyed sand blue and then put it in someone's mouth. Like I've had both of them prescribed to me. And the generic version of the paste is very, very like textural and it tastes like you're brushing with sand and it feels like you're brushing with sand. So our compliance level is a little bit lower when we're just prescribing the generic paste. Even if you prescribe the regular paste, unless you say dispensed as written, they're going to do the generic paste with Medicaid, and Medicaid won't cover. Even if you put dispensed as written, Medicaid then won't cover it if you're doing it like that. So for Medicaid to cover it and for your patients who have sensory issues to be able to use it, I do recommend the gel. The gel doesn't brush as well because it doesn't have any of those abrasives, but they're going to keep the gel on a little bit longer. And the purpose of that 5,000 parts per million is that you have that stronger concentration fluoride on your teeth. Also, I don't have them rinse it. If they read the instructions on the bottle, it says to rinse it. Don't rinse it. Just put a little rice size amount on there and spit it out. Why would you like get a medication that's entire effectiveness is based on concentration and then dilute it with water? Like that to me does not make sense. So let's see, where are we on? We got about 5 more minutes. I'm going to go into fluoride just a little bit because you'll probably have patients now that are not interested. And so this is the analogies that I like to use to get fluoride's one of your best friends in medicine when you're working with dry mouth and sugary medications. So getting them to also do fluoride is one of the best things you can do for them. The way I like to explain it to patients when they say, well, my sister has never had a cavity. She's never had fluoride. I don't think that I need it. But you look at them and you're like, whoa, you need it. You're not your sister. I explain it as that there's different environments. So in this environment over here, this roof is adequate. That roof is going to protect you. You're going to go outside and have a picnic and you're probably going to be fine, right, with this roof. Then if you go into a totally different environment, is this roof going to protect you in this environment. Is your picnic going to be fine? Like it is not, right? Your picnic is not going to be fine if you're in this environment trying to use this roof. And so fluoride in your tooth, having fluorohydroxyapatite, which will be the next slide to show you the chemistry of that, having fluorohydroxyapatite is building this shelter. This is the shelter that you want if your environment is going to be leading toward caries. So people who don't like science in general, and they're very skeptical, a lot of them do like crystals, and fluoride is a crystal. And you can buy a fluoride crystal at the rock shop, whatever mall you have. If they have a magic rock shop, you can buy a fluoride crystal. You take that crystal, you turn on the flashlight on your phone. Actually, I have one. Let's see if I can do that for you right now. You can see it. And look at how pretty that is. And that is fluoride. And then people might be more amenable to taking it, which sounds weird, but it does work. Here is the chemistry for those people who are more appealed to like learning the chemistry of fluoride and why fluoride is better for your tooth. This is hydroxyapatite. That's what your tooth is made up of. The crystalline structure of your tooth is hydroxyapatite. Looks like this chemically, looks like this in the formula. And if you wanted to dissolve that puppy, you need a pH of about 5.5. Fluorohydroxyapatite looks like this. You see that fluoride replace the hydroxyl group. Looks like this written down, looks like this drawn out. And to dissolve that puppy, the pH needs to go all the way down to 4.5. That's the critical pH. So your tooth is made up of both minerals together if you've been exposed to fluoride. The more fluoroapatite you have, the more of those crystals are harder to dissolve. And so the stronger your tooth is because it takes a 4.5 pH acid to dissolve that. In terms of things people relate to better, look at beer, IPAs, pH of about 5.5. You are dissolving hydroxyapatite, but fluoroapatite, guess what? You can drink an IPA, not dissolving your fluoroapatite. Probably don't talk about beer to your patients, but it does help in my world. Other things, we had about 2 minutes left. I'll go through a couple other things, but these other things here that you can do to help, we have hour-long courses that you can take on them. So I wasn't worried about covering the details of them today. You guys in medicine actually have CPT codes for the application of silver diamine fluoride. Look into silver diamine fluoride. You paint that on the teeth. Downside is the teeth turn jet black. It is ugly, but it stops the caries from growing. And it helps a ton of people. Fantastic. And if you put it on the teeth and then refer them to me, sometimes I can do fillings without even having to use a needle. This stuff is like magic. And here is all the brands I was able to find. There's 2 more now, but I didn't get any good pictures for them. And then as Paul was talking about, fluoride varnish, also awesome. You guys don't have any CPT codes for using iodine on the teeth, but iodine is also antimicrobial. So iodine plus fluoride varnish can help arrest caries. Not as good as studies on that, but it can be helpful. Here is what I do with the iodine. Paint the iodine on, paint the varnish on. And again, there is an hour-long course on this if you're wanting to learn how to do it in your practice. There's your hour-long course, Dr. Jeremy Horst. Definitely one of my dental crushes. Love that man. Everything he says is just all beautiful. But he goes into all the science of iodine and procedures. If you guys want to later watch a picture or watch me put it on myself, that's what that video is. This is a 4-minute video on how to apply silver diamine fluoride that I made for CNAs during COVID. During COVID, we couldn't go into the long-term care facilities. And because we couldn't go into the long-term care facilities, how are we managing caries without being able to touch our patients? Well, what we did was we had the CNAs apply silver diamine fluoride to the residents' teeth, and we were able to control caries in those few nursing homes that we were able to get into. And this is a 4-minute training video that you can watch to teach you. Or if you would like, here is a 1-hour video that you can watch as well. But you dry the tooth, stick the SDF on, and protect it. Here we'll do a not so live. And that was shot during COVID, so it's shot on a skeleton. Here's the downsides of SDF. You want to be serious with the staining. Make sure they know that it can stain their teeth if you are going to do SDF. And if you are going to do it, don't take this as your class for doing it. Like actually take a real class on it and learn how to do SDF. That's super, super easy procedure. There is more sources here. I'm taking a shot of it. If we have time at the end, we can go back. You can watch me take a shot of SDF. It won't kill you. And there is my contact. Oh, we made it by 125.
Thank you. There was one question on SDF. Have you used the SDF that doesn't turn the teeth dark?
Yes and no. I've used an SDF that says that it doesn't turn the teeth dark. And it also turned the teeth dark, but it didn't turn it as dark of black. So it's like I used it, and that's the one that has the potassium iodide in it. So you do the SDF first, and then you put potassium iodide, and when you do that, it turns this like milky white color. And then the staining is lighter brown, and it was designed to be used under fillings. And so if you're doing a filling and you're using the SDF and you're trying to do a filling on the same day, they do recommend afterwards to use the two-step process, especially if you're doing composite with a curing light. You use the two-step process, and they want you to rinse that off as well before you do it. And so that one, I've had people, I myself have not had success with doing it and not having it show through the composites, but I do a lot of lectures on this. And in two of the places where I was, I think one of them was New Mexico, there was a person in the audience that was like, I get a ton of success with composites using that. And I was like, awesome, we should connect later because I don't. Um, but I haven't noticed it not staining. It just stains less.
And then SDF doesn't turn the whole tooth black, just the caries cavities, right? Yeah.
Sort of. So SDF will it will turn any protein black. And so we say that it's just the carious lesion because that's where you have more of these proteins exposed. When you look at your tooth, most of that is mineralized tissue. And it's not going to stain mineralized tissue. It's going to stain those proteins. So if the proteins aren't exposed, it's not going to be doing that. But then we have these patients with conditions like enamel hypoplasia or rough enamel where they get proteins that are just integrated in with their enamel because it's so hard to brush off. And actually, well, I'm not sharing my screen anymore, but you saw that hideous one, right? Where there was like black all over the front. That one was a case of enamel hypoplasia, where a colleague had put some SDF on there, rightfully so, did prevent the caries from progressing, but then they were like, whoa. And so it can stain healthy tissue if it is rough, healthy tissue that has trapped some proteins.
Okay, perfect. Thank you. And with that, thank you also to Jennifer Wheeler from the Idaho Oral Health Alliance for joining us. And if you'd like to close us out, please do.
I would, Jocelyn. Thank you. Thanks to Dr. Paul, Dr. Brooke, to all of you for joining us today. The Idaho Oral Health Alliance is a statewide nonprofit that advocates for oral health for Idahoans. And we are so appreciative of the ECHO team in helping us bring this educational series to our medical partners. We understand that we're asking you to do one more thing when you're with your patients. So we're doing our very best to help you make it easy on you and help you have the tools that you might need. As Dr. Paul mentioned, Delta Dental has a tremendous resource. They are a large sponsor for this whole ECHO series. The Idaho Oral Health has some great opportunities too. We have rolled out some fluoride varnish training for medical providers, really focused on the pediatric world. And in another week, we will roll out some educational training for OBs, midwives, doulas. And so keep an eye out for the oral health and those training opportunities. And I hope you'll join us next month. Thank you.